Good evening, everyone. It is my honor to welcome you all for this wonderful podcast, a great and unique initiative by our Fogsi President, Sunita Tandulwadkar ma'am. I, Dr. B. Kalpana, Fogsi Infertility Committee Chairperson, is going to have a conversation with Nandita Palshekar ma'am, past Fogsi President and pioneer in the field of reproductive medicine. And 30 committee chairpersons will have conversation exactly at 8 p.m. every day with different speakers. Almost 46,000 FOGSI members, gynecologists, will be joining this podcast every day. We are really enjoying working under your leadership, Sunita ma'am. Fogsi President doesn't need any introduction, but for the sake of others, it is my pleasure to introduce our Fogsi President, Sunita Tandulwadkar ma'am, who is HOD of IVF and endoscopy.
Thank you so much. Today is the Kalpana and Nandita. Let's not have my official introduction. And I'm so glad that you have chosen Dr. Nandita Palshetkar as one of the faculty, the multifaceted faculty. And you are not going to have academic, but you will be asking her how she reached to this stage is so much inspiring to so many. It's not only the 46,000 gynecologists. This forum is open on a YouTube, Instagram, Spotify. So lot many other viewers can also watch. I'm so thankful to each and every committee chairperson. They are trying to get best of the faculty globally or from India, academic or non-academic, spiritual background, politician, films, so many philosophers, and I'm so glad that every day at 8 p.m. we are just having 45 minutes of a fantastic discussion, learning. Believe me, with every podcast, I also learn and I feel I'm also evolving in understanding so many parallel subjects. So I'm so glad and thankful to each and every committee chairperson who is putting so much efforts. And Nandita, it is always great to share the platform with you always. We are together in so many organizations, but in my Foxy presidential year, apart from my installation on this Gyan Pravah, wonderful to have you. Welcome, dear.
Thank you. Thank you, Sunita. And really, first of all, I must congratulate you. What a fabulous year you're doing. I don't think you have 1 minute to rest, and I've pulled you out of a meeting in Dublin. That's why it must be so cold over there. But really happy to see you, and let's rock this podcast, okay?
Thank you, dear. Thank you. And as the protocol goes, I leave and both of you only will be on the screen and will enjoy this together. And I give everyone my greetings from Dublin. Thank you. Thank you.
Thank you. Bye-bye.
Thank you so much, ma'am, for your blessings and taken efforts to join us from Ireland. Thank you, ma'am. Actually, I am standing between two beautiful, brilliant, powerful leaders, and it is my pleasure to welcome you, ma'am Nandita Palshekar, ma'am. Again, doesn't need any introduction. Past president of Fogsi with 28 years of experience in the field of reproductive medicine, pioneer in the field of reproductive medicine, specialized in Belgium and Italy, has got fellowship from prestigious Royal College of Obstetrics and Gynecology, and she is the director of Bloom IVF Center, which is present across India. And her academics, she is a pioneer in various technologies. It is beyond our limits to discuss all these technologies in 1 hour time. We will try to finish it off in 1 hour time. And she's a great academician with 103 orations, more than 100 publications, and 25 textbooks she has edited. And she has occupied various prestigious positions, past president of Fogsi, past president of ESA, and also IAG. Internationally, she was Fogsi representative for FIGO and also member of FIGO Committee on Health System and Strengthening and Respectful Care. She is also a co-chair of Reproductive Medicine, Endocrinology and Infertility in SAFOG. And even in India, with the Government of India, she is a member of PCPNDT Committee, Uterine Transplant Committee, and she has contributed for surrogacy bill also. She has received various prestigious awards like BN Purandare Award, Dronacharya Award, Bharat Gaurav Award from House of Commons, London, and the list is endless. We are really happy to have you here, ma'am.
Thank you, Kalpana.
So to start the discussion, infertility initially was considered as a social stigma, and it was treated by various methods. When we take the history, Sarah requested Abraham to impregnate her maid to get a child to avoid that social stigma. And to maintain Kuru dynasty, Satyavati also requested Vedavyasa to impregnate Ambika and Ambalika after the death of Vichitravirya to maintain the dynasty. So after a long struggle in 1978, we were successful in IVF. In 1990, ICSI was successful. So initially, IVF was not really easy getting disposables and preparing media by ourselves. It was a very challenging task. And I just wanted to know, when did you start your IVF career and what difficulties did you face at that time?
Thank you, Kalpana. I think, I started my career in 1993. I mean, that long ago. I feel when I look back, see the amount of progress that has been made. I still remember, we had this milieu system of preparing water. I mean, the whole room was occupied by that milieu system. Then, the ICSI needles and all. The ICSI was in 94, 95, ICSI, first ICSI baby was born. And I remember that I'd gone to Belgium to learn how to inject eggs. I'm trained as an embryologist also. And we had to pull our own needles. We had to prepare our needles out of the glassware. So it was a very difficult time. We had to prepare our own medias and all, and gradually how things changed. And I think the pregnancy rate also picked up. See, with every advance that was made in the lab, in the media, in clinical reproductive medicine, I think the success rate changed. Everybody knows Edwards and Steptoe did thousands of attempts before they got one pregnancy. I think when I started in the 90s, pregnancy rate was between 15 to 25%, varying between that. And today we've reached a success rate of 50 to 60% in under 35 age group. The SART registry, in fact, talks about a live birth rate of 50%. And I'm quite sure that a lot of us have that kind of results with all the successes, with all the advances in technology that has happened over the years.
Exactly, ma'am. Now the advances are such a way that even home-based semen analysis is possible. Many a times males do this with this app, or some kids, they go through this test, and the indicators are like double lines or different colors depending upon the count. And how reliable is this? Is it advisable to recommend this for our patients, ma'am? Your experience.
I think, Kalpana, patients who come to us are obviously struggling for a child. So they already have infertility. So personally, I think if we can do a semen analysis in a laboratory. For these people, it's very good. But trust me, there is a group of patients who would prefer to do the home kit. A lot of youngsters are trying and they are like worried. A lot of them smoke, they do drugs, they have alcohol. So they're worried about their semen sample. So I think these tests are very good because you can do it at home. And of course, the reliability is about, I feel, 80-85%. There can be false negatives and all, but at least those who have normal sperm counts should be relieved and should not get too stressed, and those that come in the abnormal range should definitely contact a doctor. I think I would not recommend it for all patients, but yes, I think if people would like to check it before approaching a doctor, I think it's a wonderful thing because, there is a kind of a stigma coming, giving samples, etc. So I think I am not against them. Neither would I tell my patients, if they come to me, I'd rather do analysis myself. Kalpana, do you know one interesting fact?
Yes.
Before 1957, there was no male infertility. The first semen sample was analyzed in the 1950s. And that's how male infertility existed at that point. Before that, only the woman was blamed. There was only, she had a problem. But the male factor, which today contributes to nearly 50% of the patients. It may be mild to moderate, but severe cases, 20 to 30%. But male factor contributes to 50%. Can you imagine? I don't know whether it was feminism which had a backseat. Women were not, women were only blamed for it. So I think it's really amazing that today we live in this era where we can discuss male infertility so openly and we have treatments for it, and we are successful in their management.
Yeah, in olden days, only solution for second marriage, and even after they don't conceive, they come for investigation. And as far as semen analysis is considered, we go with the WHO standard. But 20 years before, almost 20 million was considered as normal. Now it has come down to 16 million. And motility also, it was initially 50%, 20 years later, 42%. Rapid progressive was almost 25%, 20 years before, and now it is considered as 30%. Why is it fluctuating? Is it because of patient characteristics, or what could be the reason for this? And do we have Indian statistics also?
Kalpana, WHO is actually fantastic. Okay, it analyzes every decade, and I think it started in the 90s to bring out this manual of how to do semen. But remember now, in the last decade, things have changed. Like, I remember when I was studying, it was 60 to 120 million was normal. That was nearly 30 years ago, more than 30 years ago, 35 years ago. So that all has changed. And I think the semen analysis has become more functional oriented. We classify patients according to percentiles, and the function of the sperm is very important. And I'm telling you, in the next 10 years, you'll see even the DNA fragmentation, etc., added to this test. So personally, I feel that the pollution, the changes in the environment, the stress has really reduced the semen count. But what has happened at the same time is that, it's the Darwin's theory of evolution. You cannot have human beings becoming extinct. So this count the normal count has reduced, and we are definitely getting more pregnancy. They're more fertile, so there's no overdiagnosis because of this. Otherwise, when you considered it a higher level, there was underdiagnosis of male fertility. So I think it has definitely altered our treatment protocols. It has helped us identify men and not give anxiety to a lot of people. So I think overall it's been a great change.
And I want to get your experience. Motility is one of the most important factor in semen analysis, and by various methods it has been checked manually, sometimes computer assisted, sometimes AI based. Uh, one do you prefer? Because each procedure has got its own merits and demerits. With CASA, we can get curvilinear and lateral head displacement. Sometimes the count is, there is some false reports about counts. And so if you want to differentiate 100% immotile sperms from dead sperms, then how will you manage? What is your experience with these things?
See, first of all, Kalpana, I think now treatments, I mean, the technology has really advanced. So CASA is not that ancient, and it's not that crude as it was before. I think more and more I depend on them for the analysis of the sperm. Definitely, I would trust those reports today as compared to 10 years ago. Definitely. And also, as far as motility is concerned, we still follow the HOS test, hypoosmotic test, where you put in a hypoosmolar solution, and if the tail curls, that means that sperm is alive. And if the tail remains straight, these are all dead sperm. So to differentiate between dead and alive sperm, I think HOS test is really, really good.
And coming to morphology, various criteria have been given, like oval head, 40% acrosome and vacuoles, no vacuoles, and mid-piece, slender one, and 30% cytoplasmic residues. And it is really difficult to manually look into it. And it is also said that it has got a correlation with DFI. How do you go if you get total teratozoospermia? Do you have any preference for particular deformity, whether natural OUI or ICSI or IMSI? Would you, because you have
See,
been
I
doing.
think sperm morphology is important. As we know that about 4% is normal, 2 to 4 we can do IUIs, between that range. And if it's 2 and less than 2, I would rather go for IVF or MC. So I think we need to, and also remember that you can use these advanced technologies like MC, like, hyaluron, to identify intact sperms. We use MAC, we use, microfluidics now. So all these technologies actually help us, get a good cohort of sperms, and those can be used for IVF or, ICSI. And I'm really, really happy. And now artificial intelligence has really helped us, because there are so many programs now where you can actually, it reduces the time to find a normal sperm, especially when you have hardly 1% normal or 2% normal. The embryologist spends a lot of time trying to identify that normal sperm, whereas AI will fatafat label it. You have the sperms labeled A, B, C, and it'll say pick up C. So it's very, very quick, saves time, and reduces the exposure time of the egg also. So you can do it simultaneously. Otherwise, what my embryologist would do is would take the sample, pick up the normal sperms identified by IMC and all, put them in another droplet, and then, in the prepared dish, put the eggs, so that the eggs are not waiting for a long time under the media. So I think all these things, artificial intelligence has come in a big way. And remember one thing, Kalpana, ChatGPT has come now in the last couple of years. We've been using artificial intelligence for, I think, a decade now in our labs. So I think it's amazing. And the new programs which are coming, especially for azoospermia, for testicular biopsy, checking it also. It is an amazing program where it cuts down the time to, I think, 1/5 or 1/10 probably of what an embryologist would take. We do a lot of azoospermias, non-obstructive azoospermias, and I know my embryologist spent a couple of hours trying to find them. Now with this AI, you can just find it in like 15 minutes to 1 hour.
Yeah. With this CNN algorithm, have you concluded that your blastocyst formation and pregnancy rate is significantly improved because the exposure is very short and within seconds it can track the sperms? And do you feel a difference between older techniques and newer techniques?
So let me tell you something. We use artificial intelligence even for the eggs. So the oocytes also graded. Whether what is the chance of that egg becoming a blastocyst, whether it's 40%, 20%, 50%, etc. So that also, in addition to this, I think, and at the moment, in IMSI, what we've done is we identify the sperms, we put it in a droplet and do it. So I think it definitely, our success rates are on par with the American success rates. So it has definitely helped. And the minute our success rate drops, we go troubleshooting, we check what is the problem, check the disposables, check the media, check the incubators, check everything. So I think it's a constant quality check which you're doing every day so that everything works perfect. But I am telling you, AI is come in a big way to assist us um, take decisions and to help us improve our success rates.
And
You can counsel the patients, Baba.
yes,
The egg quality is good, bad, whatever, ugly.
even with AI, we get probable pregnancy rate with this
Exactly.
this hormonal profile and even with lifestyle. So counseling becomes easier for us. And
Absolutely.
DFI, yeah, you have been talking about it. Is it over talked because we don't have enough literature evidence to go for that? And do you go for DFI routinely or in selected patients if DFI is high? Which is your choice, MAC, microfluidics, or Pixie, which is giving you higher success rate, and the selected to a group of patients like that?
So if the DFI, I mean, first of all, I'm a tertiary care center. So literally I get patients with 2 failures, 3 failures, 5 failures. So the first thing that I do is DFI for all patients. Of course, when I get patients who are coming for the first time and all, depending if I want them to spend money or not, if the sperm count is normal, I don't do the DFI. But of course, ask for their habits also, like smoking, alcohol, drugs, then gymming, steam, sauna, all those things can increase the DFI. So if the DFI is high and I've given them antioxidants, etc., and it whatever we give them all this, supplements which are required, and then I would prefer microfluidics. If it's a good count, microfluidics really helps. The other technology is MAC also. MAC also gives me the best because apoptotic sperms are removed by MAC. And of course, those are the ones, and the DNA is also selected. So microfluidics and MAC really help you select the sperms which have the maximum potential for pregnancy, good DNA, good they're alive, and the damage is less.
And I know you have been doing metabolomics for embryos. It was quite popular, and for sperm, you were the pioneer in that field also. So, as far as sperm is considered, sometimes it is said that if creatinine is really high, it is mostly immotile sperms, and glycine and serine, if it is low, it can be related to mid-piece defect. And is it really useful practically? And what is your impression on that?
See, we got metabolomics very early, actually 15, 20 years ago, I think. I don't even remember when. And then they withdrew the machines because it was not giving fabulous results. Even today, it is in the research arena. We don't have it yet in the clinical arena. And so I think with the advances in technology, that is going to be, see, what we want, Kalpana, is overall picture that the embryo is normal without doing as much as invasive work as possible. So metabolomics, the embryoscope or the time-lapse imagery which we do, the non-invasive prenatal, chromosomal screening which is done. So all these non-invasive methods are going to become the whole mainstay of the lab, because you don't want to play around with the embryo. So yes, metabolomics today, no, definitely not used, but in the field of research, it is being used. And I'm telling you, down the line, it is going to come into clinical practice, and we will be all having it in our labs. But at the moment, the time has not yet arrived.
And moreover, for selection of oocyte, spindle view during ICSI was quite popular few years before. When we are talking about male infertility, do we have any selection of sperms depending upon its bifringence? Because it is said that mature sperms have greater bifringence. What is your experience? Have you been using at that time, or should we wait for some more time to look into it?
See, we are using the spindle view, definitely. And I feel for patients with frozen eggs, with cancer patients who have frozen their fertility, it definitely helps because the damage to the oocyte is less. And I also think that maybe you can use it in patients with very low sperms, non-obstructive azoospermia, so that you don't want that sperm to get wasted. See, if you go through the spindle, you're damaging the oocyte. So we definitely use it in such patients, very low sperm count, etc. But bifringence of the sperm, I don't have experience and I've never really used it. So I can't really comment on it. And I think, we would have used it if it was really in clinical practice. Us, we are like small children in a toy shop. We want everything, any technology. We are totally technology crazy. I love my technology. I always say my lab is like my spaceship, with fantastic things in it. So yes, definitely, I would love to get that if once it comes into clinical practice, but I don't have experience in that.
And the most important now is piezo-ICSI with elderly patients, where ultra-thin needles are used and piezo pulses are used to penetrate zona pellucida and plasma membrane. Without aspiration, sperm is injected. And what is your experience with piezo-ICSI, ma'am?
Yeah, we have the piezo-ICSI with us, and it's a very skilled technique. It has to be mastered. So it is a phenomenal instrument, and it causes minimal damage to the oocyte. And that is what is the beauty of piezo-ICSI. So, eggs which are frozen, hardened, I think piezo-ICSI works beautiful in them. And I'm telling you that at one point, right now, we are not doing it in all patients, but I think at a point will come in our practice when we do piezo-ICSI for all patients. Sorry. So it's a wonderful technique, and it's an advanced, but it is a very skilled technique. So and the machine is very, very sensitive. So you have to really take care of that machine. The setting has to be right. A lot of time if the setting goes off, you can't really use it, So it is a piece of equipment which can be used very beautifully in selected patients at the moment.
And robotics is into gynecology very nowadays. Everyone is crazy about robotics. And about robotic ICSI and fully automated ICSI, if it comes into practice, that would be the fantastic day, I think. Everything is automated, selection, AI-based sperm selection, immobilization by laser, and piezo-ICSI automatically. Then it is the fantastic day for the gynecologist or clinician, I think. What is your experience, and when can we get? Because ICSI is quite popular almost 4-5 decades after we had first ICSI baby. And what is your opinion about this?
Okay, Kalpana, the last time I was at ASRM, they had this beautiful machine of ICSI, which was totally run by robotics. It exists, it is there, and a few labs are using it. And I'm sure by now they've incorporated AI also into it. Because I think, I heard this lecture by Carlos Simon. He said, lab on a chip. And that's actually what is going to happen, that the lab is going to be controlled by a chip. Everything, all the processes, once the ICSI is done, the embryo through the microfluidic channel will flow out. So it won't need humans to pick it up, etc. It'll flow out into the chamber where it's going to cleave and grow, and that'll be straight put in the embryoscope. So I think, yes, we are going to see it. It does exist right now. But I'm always worried, like you're dependent on a machine. What if the machine goes haywire? you know, so I think embryologists obviously are worried about that. And I'm worried once robotic ICSI comes, embryologists will lose the skill of ICSI. See, any skill, if you want to maintain, you need to be doing it. And that is my worry also. But we have to take these advances in our stride, and I'm sure there'll be other jobs for the embryologists to do. So yes, it will come. It already exists. It's just that I think it's too expensive right now, and also it needs to be fine-tuned.
And we know very well about in vitro maturation of oocytes. What is your opinion about in vitro maturation of immature sperms for non-obstructive azoospermia if we get, and what would be the
We don't really do that, but I think there is a lot of research going on to mature the sperms, with not much success, unfortunately. But the mouse sperms have been created out of the stem cells. So yes, we are heading towards that direction. So I don't think it's so difficult to convert the primary spermatocytes into spermatogonia. So no, we don't do it because there are a lot of ethical concerns and what effect it will have on the offspring. So it's not like oocytes, where oocytes are matured in vitro and they're giving good results. There's enough research, there's enough data, evidence created on that. But I don't think there's much data on uh, this, because Kalpana, I really believe that it's a very new science, the male infertility. As I said, it was only discovered in 50s. So just 70 years old, whereas the reproductive medicine in a woman is like 300 years old. William Harvey was the first person in 1500s to talk about it. So progress is a little slow, and but we are waiting and watching. I'm sure they'll create a 3D printing of the testes and plant the spermatogonia onto that matrix and create a testes. I don't know if it's been already created, but I know that mouse sperms have been created from the stem cells and injected and given birth to a litter.
And you were talking about stem cell therapy. If it is from spermatogonial stem cells or sometimes pluripotent stem cells or embryonic stem cells, if that is successful, will the males be extinct in another century, or what would?
I don't think males will become extinct, but probably reproduction will happen in the lab, and the sex is only for pleasure. So it's something, I think it's amazing the way, science has progressed. And like even in non-obstructive azoospermia with microtessae, I think we are getting a retrieval rate of 50 to 70% and a pregnancy rate which is kind of like equivalent, a little lesser than the normal, but yes, we are getting good results. And I'm really happy. Then we have another technology called sperm VD, which can store single sperms.
Mm.
So, like the other day, I had a patient who had ejaculated sperms, but very few sperms. So, 12 sperms are actually stored in the sperm VD. So it's amazing the way technology can help us help these men. And I think ICSI was groundbreaking. It totally uh, brought forward the thing that no male is infertile, you know, literally. So I think today we've mastered ICSI. We are learning how to deal with the difficult cases of male infertility, and it's amazing. Another thing that I really want to mention is varicocelectomy. You know, varicocelectomy is a much abused and used
Yes.
surgery, but I personally feel my experience with varicocelectomy is if it's clinically visible and you operate on it, you definitely get better quality sperms. If even if the count doesn't go up, your results in ICSI improve. But nowadays, you know, Kalpana, the other day I saw this patient, but the wife has a AMH of 0.9. So how long do I wait after the varicocelectomy? So then I take a decision to go ahead with ICSI. You understand? So I mean, we are seeing so many young girls with low AMH. So it's very difficult. I think individualization of therapy is really, really important. And we have so many tools. Today we have, recurrent pregnancy, recurrent implantation failure app to tell us how to individualize the treatment. So I think all this knowledge of you and me has been taken, and the engineers have created all these algorithms, and I think it's going to be a win-win for the next generation.
Exactly, ma'am. And we have been talking more about aging of females. Aging of males is also really important. And even though literature says that even at the age of 94, we had paternity. And in Bible also it is said that Noah's father had his son at the age of 187, live about that. The literature says 94. But obviously,
You Hasna had a baby when he was 80 plus, I think, or probably 90.
so obviously the DFI goes high, and it has been said that various disease, Alzheimer's or disorders are associated with paternal age. You have contributed for ART bill also, which says that donor between 21 to 55. So a single donation is acceptable at this point, and 55, is it too high for donation? And what is your stand on this?
I think 50 is a cutoff for the sperm, because the sperm quality starts deteriorating and every decade it worsens. And of course, there will always be people who will have babies at 90. That is not a problem. But as you said, the count, the motility, the quality, the morphology, it all undergoes a change. There is aging even in the males, and all that you see. And there are diseases. In fact, there was a study which said autism is more in older fathers, when the fathers, are much at an old age. So I think gradually we'll see the effects of aging on the offspring. There are lots of studies going on, and the younger the patient is, I think the husband is, the better it is. As a donor, I would not go beyond 35, 25 to 35. No patient would opt for a donor unless it's a known donor, or, that kind of a thing.
You were really interested into genetics, I think, and if what is the role of genetics in male infertility, especially azoospermia or congenital bilateral absence of vas difference, whatever it is, and what is the role of PGT and how successful it was in your experience?
See, let me tell you, today genetics has really, really bloomed. Nearly 40% of the male infertility is actually genetic causes, but we do not know them. What is identifiable is by doing, microarray, by doing NGS, etc. We do sequencing sequencing. And patients who have azoospermia, microdeletion should be done. Why microdeletion? But remember that there are 2000 genes which are associated with male infertility. We can't pick up each and every one and study each and every gene. So there are a few genes which are studied, like FSH receptor gene, LH receptor gene. You know, all these genes are studied, and I'm doing precision medicine. And there is a probe which studies the genetic makeup of the man, fragile X, in the women. Though, so all these can be studied, and if the FSHR G receptor polymorphism is there or LH polymorphism is there, you can use FSH injections in these patients, and you will definitely get a better. Then androgen insensitivity also. Sometimes it's partial. They are not the Sertoli cells are not sensitive to the testosterone. So all these polymorphisms you can pick up. So today, I think with the congenital absence, the CFTR gene, the microdeletions, and the polymorphisms, a few of them which are picked up, you are able to identify at least 10% of the genetic causes, and some of them can be treated. Some of them need, intervention like a microtessay or a obstructive, just aspiration if there is congenital absence. So definitely, I feel genetics has a role. It will help us. It's like precision medicine is genetics. So it will help us in individualizing therapies for the husband. And we're waiting for more evidence to come in so that it becomes into clinical practice.
You were very popular about oocyte cryopreservation, ovarian tissue cryopreservation, and what about testicular tissue cryopreservation?
I have not done that.
Hmm.
But I feel that, the tissue should be frozen. When we do microtessay and all that, we freeze the tissue and we keep it, because you never know. Supposing you find 0 sperms, we still freeze the tissue and keep it, because maybe 10 years down the line, we'll be able to create sperms from them. But I have never thawed them and reused them. They're frozen.
Okay. And you were the pioneer of intravaginal culture. How was it doing? And please explain that.
Intravaginal culture has a very special container in which you can put the eggs which are retrieved. The eggs are washed with, culture media, and then along with the cumulus and the sperms. Sperms have to be good. So you either do double density gradient or MAC or microfluidics for IUI. Okay, you don't take for IVF, and you put it together, and you can put it in this chamber, and then this chamber is then inserted into the vagina. And then after 3 days or 6 days, you get them out as per your day 0, day 1, day 2, day 3, or day 5 embryos. You take it out and get that culture media out and see how well. You have to clean the embryo. You have to remove all the cumulus cells and all, and you have to see if they're fertilized. We don't do it anymore. It was just something, it's like something's come and they disappear without making a flutter. That was what in vivo invo. It was called invo.
And for non-obstructive azoospermia, will you go directly to micro-TZ, or will you go for other procedures? Or you have selected
one patient which I had, okay, my non-obstructive azoospermia, we go for micro-TZ. There's no question about it. But there was this patient, actually, she was from another state, I think from your state only. And the husband, we did 2 micro-TZs 6 months apart, and we didn't get any sperms. So we gave the husband FSH injections, and then we told him every day, come and give us a sample, every day. And you won't believe it, every day he came and gave sample for 1 month, and we found sperms in one of the samples. And those sperms were used to inject the oocytes, and we got a live birth. So in patients, like certain religions don't allow donor sperms, those who don't want donor sperms. In those patients, we do give this a try. Use FSH injections and, take a sample every day. So, in fact, if the sample is poor, sometimes, the husband has a normal count, but on the day of the pickup, he gives a poor sample. So, we collect the second sample within half an hour to 1 hour. And the second sample, a lot of times, has good, sperms. So, multiple samples is good. Then the other thing is, my andrologist would tell me that if the DFI is very high, like 40-50%, you can do a TESE, a testicular biopsy, and get better sperms, because the passage of the sperm through the epididymis, through the vas deferens, sometimes increases the DNA fragmentation. So it's better to go into the testes and aspirate the sperms. So in those patients, I have done that also.
So this is a legal question. If a patient had frozen his sperms and probably because of some life-threatening condition after his death, who can use that? If parents are claiming that without, we don't have nominee, all those details in this form. So if it is not given, then who can use it, and what is the center's responsibility in that sperms?
I think the law is very, very clear. I'm very happy with the government of India who's made this law, that when we take the sample, we have to have a nominee. So I think if it's not there in the form, put it down, because it's your duty to take a nominee. And if the person has passed away without any nominee, the sperms cannot be given to anybody. The person whose sperms belong to, he has to say, okay, if anything happens to me, it has to go to my father, it has to go to my mother. But if he doesn't leave a nominee, I think you have to not give the sperms to anybody. Also, we have a lot of young boys, 14, 15, who have had cancer and are undergoing therapy. So we freeze the samples. Now, in that case, once the child turns 18, he needs to do. I have no clue if he dies at the age of 16, what to do with the sperm. I think we need to ask the lawyers that.
Okay. So I think we have discussed starting from analysis to automated lab. Please share us some interesting case scenarios, difficult case scenarios you have managed in your 30 years of experience.
Oh, wow. Male factor. You know what? This is not very interesting, but I must tell you something. See, male infertility always comes with a stigma.
Yes.
Right? None of the males want to accept it. In fact, they will not even tell their mothers that the problem is with me. This was a long time ago. Now this generation is different. The girls are there's that, okay, come on. If it's male infertility, you better own it. But this was like 20, 25 years ago. I still remember there was this man who had male infertility, and we did 2 ICSI cycles, and IMSI, we had bought it new. So 2 failures. So we did IMSI on him, and he conceived. And it was amazing because, this man came on television with me and accepted it to everybody that, I had male infertility. I had a problem with sperm defect. So I think this case really stands out because of that. And I mean, it's amazing how a person can own up. And I think we should treat infertility like a disease. Nobody says, I don't have diabetes. They don't hide diabetes, or they don't hide hypertension. So that way, infertility also should not be a taboo, should not be a stigma. So I think this was wonderful. I mean, especially in the 1990s, for a person to come across and say that I have male factor. Another very interesting case that I had was globospermia. It's hardly 1% incidence, but there was this patient who had globospermia. And what the head was slightly, we couldn't pull it in the ICSI pipette at all. Somehow we are finding it difficult to do ICSI with those sperms. So in that case, we were used to forming our own pipettes, no? So we actually pulled a pipette to get that right, so that that sperm could be aspirated. But now, of course, you get it, and you can do ICSI with globospermia, uh, uh, you know, sperms, and you have to do oocyte activation. You put that calcium ionophore and activate the oocyte, because globospermia doesn't have an acrosome. Its membranes are not fused. So there's no, oocyte activation. So you must do oocyte activation with these patients. I think lots of cases, but these are some of the few cases. As I told you, the sperm VD, only 12 sperms we found. We've frozen them and we've kept them. So it's amazing how technology helps these kind of difficult cases. Another patient who just underwent 8 IVF cycles with me. I mean, I was like, do you want to go to somebody? But the faith that that patient had. And we did micro TSA for him, and we had frozen his samples and sperm VD, whatever sperms we got. And finally, he went home with triplets. Because obviously, 8th cycle, we are putting in more embryos to get the patient pregnant. And finally, she got triplets. And she delivered at 27th week. We had to keep all 3 of them in the NICU. And she sends me pictures of the babies. It's amazing how technology and faith. I think, Kalpana, you're an IVF specialist. Faith is really, really important. And it really helps give us positive results. And I think it's a holistic approach. Diet, exercise, sleep, mental health, all these things together, along with our expertise and technology, I think really gives good results.
So finally, with the decades of hard work, you have reached this position. And what would you like to tell message for the young gynecologist and people watching here?
One thing which my father taught me, okay? He said, whatever you do, do it with passion. So if you have passion, if you have liking, if you have focus, the hard work is not hard work. It's just something that comes naturally and you just do it. I think that is what is important. Like today, I've gone to DY Patil. I've come again to Leelavati. Then doing your podcast, I have another podcast. So I really enjoy my profession. I think that's what you need to do. You need to be really passionate about it. And if you love your work, you can't be tired. So there should be no word in your dictionary that I'm tired. If it's the work which you love, which you're doing, definitely you can't say tired.
Yeah. Thank you so much, Nandita ma'am. It was an encouraging podcast for the youngsters. Thank you so much for spending almost 1 hour with us and sharing your knowledge to all 46,000 gynecologists. Once again, I would like to thank our Fogsi President, Sunita Tandulwadkar ma'am, who had given this wonderful opportunity to all the chairpersons. Thank you.